go. All right, so now we have PET image quantitation. So to get the SUV values, we need the means of the region of interest in activity, which is millicuries over milliliters, divided by the activity administered in millicuries, and then the body weight in grams. Okay, and then your resulting answer should be in grams per milliliter. Okay. And then you have your semi-quantitative index. And when a PET camera is properly calibrated, it is able to assess the millicuries per milliliter of tissue, which is right. And you also need to put, like when you guys do your dosing, you know how like you take what you actually withdrew and then what you gave to the patient, and then you subtract the difference. That also aids towards getting the proper SUV value. Okay, so it's very important that you always get the residual that is left in the syringe, because that minus the amount that you actually gave is going to give you the true amount of what you gave. Okay, so what was in the syringe subtracted by what is left in the syringe gives you the true amount of what you gave to help calculate the SUV. SUV measurements may be used to characterize a lesion with respect to its glucose metabolism.
So that was what's in the syringe by what's left in the syringe?
Right. So the dose that you drew up for your actual study, and then the amount that was left in the syringe after you gave it to the patient, the difference of those two is what you really gave the patient.
Okay.
So with the brain, we have the gray matter of the brain is high in FDG uptake due to the cells of the gray matter having high metabolic rate and actively uses glucose. So PET brains, normal distribution of FDG is usually highest in the gray matter of the cortex, the basal ganglia, and the thalmi. And there's decreased frontal lobe metabolism is common with aging. The thalmi, the basal ganglia, the cerebellum, and usually, the visual cortex are not changed with aging. Areas of the brain that's stimulated by activity during FDG uptake include the visual cortex, the auditory cortical areas, and motor cortex. So if the patient moves or if they speak or if they listen to something a lot, you're going to see increased uptake at that time in that area. Okay. Diachesis is a phenomenon which causes decreased focal area and reduces area of metabolism due to neoplasm, stroke, and trauma. And that's usually seen in the cerebral hemisphere. So have any of you guys done a PET brain, or you just have done a whole body for tumor?
Whole body.
Whole body.
Okay. So if any of you have done, will do a brain in the future, what you're going to realize is that the patient comes in and you're going to quickly do what you need to do as far as injecting them, but you're going to put them in the room and you're going to turn everything off, and you're going to encourage them not to read anything. You're going to tell them to close their eyes, because even with them looking around, that is going to cause increased uptake in that visual area. Okay? So in the future, that's basically what you have to remember. Let me know if there's anything to write, because I didn't pull up yours, the student version.
It's only a little bit. Diachesis was the only thing.
Okay. I think I'm pulling up yours right now just to go with it and make sure I give you enough time. All right, here we go. So now here we have a cross-cerebral diachesis. This is the functional reduction in the cerebellum, usually due to cerebral lesions. It can follow a stroke, tumor, or epilepsy, or any other type of intracranial tumor. It should be noted that there is a direct relationship between the size of the lesion and the incidence of the cross-cerebral diachesis. Okay? So remember, diachesis is a phenomenon which causes a decrease focal area to reduce the area of metabolism because of the neoplasm. All right. So you're looking at here would be this area here in relation to this area. Okay.
Can't see you.
Oh, sorry.
Okay.
Is that better? There we go.
Yeah.
All right. So here you see the cerebrum, right?
Mm-hmm.
And then on here, your cerebellum, there's increased uptake here. Okay. And that's because of the neoplasm that is present in that area. Okay.
Okay.
All right, so brain imaging, what would you do? The patient prep. The patient has to be NPO for at least 4 hours prior to reduce insulin levels to diminish uptake by organs such as the heart. Then the contraindications would be high glucose levels would reduce the tumor uptake. Your radiopharmaceutical is going to be 10 to 20 millicuries of FDG. The injection of imaging time or injection to imaging time would be 60 minutes, and you would void before the imaging. Your method of administration would be IV. And for brain imaging, the patient needs to be quiet in a dark room for a few minutes before injection and 30 minutes after injection. Your imaging time would be 30 to 60 minutes, where the patient's going to be supine with their arms down, and the view would be just a routine head. So it's 10 to 20 millicuries of FDG. Your imaging time would be 60 minutes. Your patient position would be supine with their arms down. All right. This is a patient who has epilepsy, and this is a fused PET MRI image. Okay. Oh, let me zoom it. There we go.
So this is one camera that's PET and MRI, or is it
Yeah,
two separate?
there's cameras now that are PET and MRI. When this actual picture came out, I think they just fused it, but there's actual PET MRI cameras now. And I think they just, because they were trying to work how to get the actual syringe shield in that magnetic field. So I think they came up with an actual syringe shield that's able to go in so that you can go ahead and give the gadolinium and so forth, or the FDG, and still be in the magnetic field in the room. So this could be just a possibly fused one, and then, you know, now if you see the pictures, they're a lot nicer. Okay. All right, so now we have vocal cords. How do I minimize this? There we go. Activity in the neck may be seen if the patient was talking at the time of the injection, signifying vocal cord uptake. The tongue uptake may also be seen. It is best to have the patient remain silent during injection and early uptake of radiopharmaceutical to minimize activity in this region. So remember, your patients have to be like straight quiet. You want to turn off the lights. You want them to close their eyes. You don't want them thinking about anything, which is going to be hard because they're there for a reason. So they're going to be thinking anyway. So you just want to encourage them to kind of like stay quiet and not do anything. Okay? All right. Tonsils, salivary glands, and your thyroid. The tonsils, lymphoidal tissues, parotid, and submandibular glands normally accumulate FDG. This activity should be symmetrical. Activity also seen in the soft palate, vocal cords, and vocal cord muscles. This is why it's important to have patients remain silent and relaxed during and after injection. Thyroid activity is normally not seen. If seen, it usually signifies an abnormality. I think that's a test question. All right. See this thyroid activity. So ideally, that should not be there. Okay. Your thymus. It is a specialized organ of the immune system. Those all right, so this is where it would be right here. So if it was here, it would be obviously your thyroid, right? And that would be normal or abnormal.
Abnormal.
Right. And then this is your thymus. So you need to make sure it's kind of in the center of the chest, not the center of the chest, but above the heart area. Okay. And if you see the thymus, what does that mean?
Mm.
They're rebounding from chemotherapy?
Chemo.
Okay, exactly, chemotherapy. All right, so now we have muscles. Muscles, the resting muscle activity is usually not seen. Normal increased activity is seen in the shoulder girdle, upper back if the patient is tense during injection. Heavy exercise within 24 hours before exam can increase muscle uptake along with elevated insulin levels. Neck and tongue activity may be seen due to the vocal cords having increased uptake from patients speaking during the uptake period. At any specific location, symmetry versus diffused, you'll have linear uptake is helpful to distinguish normal activities from the pathology. So what you want is to make sure, well, again, that they're quiet, and normal activity that you will find will be increased uptake in that shoulder girdle, okay, or in the upper back area. Not too much, but in that area. But if you see too much, it's because they've been exercising, doing strenuous activities, okay? And it usually should be symmetrical. If it's linear or diffused, then you have to start wondering, what is that? Okay, does that make sense?
Yeah.
Like if there's uptake in that shoulder girdle, it should be on both shoulder girdles, not on one.
Just. Mm-hmm.
Does it make sense?
Right.
Yes.
It should be on both, not just like, let's say this wasn't here and it was just only here, then you would have to suspect something. You see what I'm saying?
Mhm.
Okay. Brown or USA fat. Mostly predominant in the upper chest and the neck. Primary function is to generate body heat. FDG is known to accumulate in brown fat. Brown, also known as USA fat, which is uptake in supraclavicular area. The reason for this specific area of brown fat accumulation is not known. Low Hounsfield unit numbers. Uptake may be due to muscle stimulation from possible anxiety or shivering. Patient with activity in the neck fat usually also displays activity in mediastinal fat, paravertebral, and posterior intercostal areas. So ideally, when the patient comes to get their FDG study, you put them, I know the area is always cold, but you want to give them a blanket to try to keep them as warm as possible to avoid this brown fat, okay? Have you guys seen this when you have done your studies? Or
No.
did you even know what that was? Maybe let me show you this picture so you can see. Did you see this before?
Negative.
No.
No, okay. Good. Then you guys are keeping your patient nice and warm. Because that's exactly what it would be right here. Okay? And then in that mediastinal area. All right?
Is brown fat a specific type of fat? I don't understand.
It's fat in your body. And basically, I don't know why they call it brown fat, but it's just a type of fat in your body. And when you're shivering and you're trying, because your body's reaction to cold is to shiver, and this is what it produces when you're doing an FDG study. So you get an increased uptake in that in that fat area.
Okay.
Okay. I don't know why they call it brown fat, but it's just fat. Call it adipose tissue. Huh? So this is what it will look like here. Okay. Sometimes it's not as prominent like this, because that's really crazy. This person was straight freezing. But it'll look like this. And you guys can zoom it on your end so that you could see it. And then here on the mediastinal area. Okay. You'll see it here. Okay.
So we're just going to assume that's always going to be fat compared to like some type of
Yeah,
cancer?
I was just going to say the same thing.
You have to look at what is the diagnosis for the patient and what they're there for. So if they're doing a whole body for, breast cancer, right? And if the lesions that's on the bone are not on the bone, you see how they're kind of on the mediastinum, like on the sides of the bone? That's the difference with that one. Okay. And then of course on the top here, it's usually on the very top, like the
clavicle.
Thank you, in the clavicle area. So nothing's really going to be in the clavicle area. And if you do suspect that there is something, it's usually not symmetrical. It's usually diffused and, because metastasis does not show up in a pattern. Does that make sense what I'm saying?
Yeah.
Yes.
Yeah.
So basically if you think you're seeing something, the best thing for you to do is put it in a coronal, look at the MIP or look at this fused coronal, and then start looking at the pattern. And then if you see that you have symmetrical patterns going on like this, you know that that's brown fat as opposed to a possibility of metastasis. And if it was metastasis, it'd be actually in the actual bone itself. You see how this is nice and clean? Right? So as you go along, it would be like in here, not on the sides of the vertebrae. Okay? All right, aorta, lungs, and breast. Aortic wall is usually seen in older patients, and the uptake can be demonstrated as a focal or a band-like area within the lower descending thoracic aorta. With the lungs usually have low uptake and may even be photopenic when attenuation correction is applied. But before attenuation correction, the lung appears with increased activity. And that's pleural effusion. Pleural effusion does not accumulate activity unless it is malignant. Okay? So you usually will have low uptake in the lungs, and it'll be photopenic when you do the attenuation correction. But before attenuation correction, the lung will appear like they have activity in there. And pleural effusion will not have activity unless it is malignant. And with the breast activity is usually very faint. Fatty breasts have less activity than dense breasts, but the SUV value in either is usually less than 1.5. And what's the SUV value that will tell you that it's malignant? We covered that yesterday. Greater than 3? You guys are going to need to know that. All right, so this is pleural effusion. The more FDG uptake in the pleural effusion, the greater the chance of the malignancy. All right. So going back to what we were talking about, this would not be brown fat. You understand?
Okay.
It would be up here on the soft tissue. Does that help?
Yeah.
All right. This is the tumor in the right breast. I think your picture might be better than mine. It's kind of blurry. Okay. All right. So what happened in that picture?
Patient
Hmm?
Let me look.
What do you think is going on in that picture?
Patient ate
Yeah.
something.
No, you have a female with lactating breasts.
Oh.
What about the liver? It looks like it's empty. The gallbladder.
That's the kidney. That's kidneys. These two here.
Well, I was gonna
That's
say the liver specifically.
Yeah, this is the kidneys, and then they're going to empty out into the bladder. So this is lactating breasts. Okay, this is what it looks like.
Why
Oh.
why does it have increased uptake?
I'm glad that you asked that. So your first of all, your breasts are constantly stimulating because you are producing milk. So it's metabolically doing that by nature, and your lactating ducts are in constant working until they dry up. So now the next question is, can a woman who is breastfeeding have an FDG study?
Depends what it's for.
So she could pump and dump?
Also, this
But-
picture is proof that you can.
Well, this picture is proof that you can. Exactly. Okay. True. But more so, what I want you to understand is that the milk itself is not going to be radioactive. It's just the breast tissue.
Oh,
Oh, that's cool.
why not?
I don't know. When I read it, I was just like, what? How is that even possible? But it makes sense. Your breast tissue is the tissue, but the milk itself is not radioactive. The breast tissue stimulates the production of milk, like your hormones and the ducts. They stimulate production of milk, but the milk itself is not radioactive.
That's weird.
That's
Isn't it?
weird.
Right.
Yeah.
Because it's a
very,
bodily
very
fluid.
I agree. Listen, I agree with you. And when you guys read your textbook, you'll see it. It's in there too. And I think it's a test question. So be sure to check it. Make sure you read that little section because it's in there. When you invert the image, what do you see? Let's see, where's mine? That's why it's like, I don't see anything.
You see the lungs?
But there's no up. Oh, well, I don't know. I was gonna say there's no the breast. It's a different person too. I don't know.
Wait, what happened?
I'm going to remove this picture from the slide. What does inverting the picture mean?
Putting it upside down, inverted. I don't know.
No, you're changing the contrast of the image.
Right. So if you invert that picture, what do you think would happen based on what we were talking about, the lungs? Wouldn't they be look photopenic?
Yeah, because it's air.
Right. Does that make sense? When you go back to your couple of slides up and you look at the lung pictures are clear, or I should say photopenic. Does that make sense? This? No, it's about if you invert the picture, your lung field should not be seen. Like right now, you're seeing these lungs, right? If you invert it, then you will not see the lungs and you would see more of the body.
That's it? Oh, okay.
That's all that it is. If you invert which picture? Correct. That's all that you want. That's all that it is. Exactly. It's because this ideally is not your typical pet picture. Is that correct?
Yeah.
Right. Correct. That's the idea. It's just critical thinking. That's all. Maybe it's too early in the morning for that, right? According to Larry. We start at 12. All right, ready? Your gastrointestinal tract. Activity in the bowel varies depending on intensity and location. The esophagus should have a low level of activity uniformly throughout, and activity usually is greater in the stomach than the liver. Hernias can interfere with the diagnosing neoplasms due to intense focal activity. All right, the small bowel usually has faint activity. The colon usually has intense activity, usually inoperative to view the MIP image of the colon to distinguish normal activity from the pathology. So then you have diffused activity is usually non-pathogenic, segmental activity or segmental uptake is usually inflammation, and nodular focal uptake is usually due to lesions, adenomas, and carcinomas. That is in red for a reason, you guys, okay? Liver usually has more activity than the background blood pool, and the gallbladder and pancreas are not usually seen. If it's seen, that means there is an abnormality. I hope you're pulling what's important from these slides. All right, so the GU tract, almost always seen activity in the urinary tract since more than 40% of injected activity is excreted via the kidneys in the first 2 hours. The bladder activity is intense. If the pelvic area is of concern, then catheterization would be required, which is normal and understandable. The uterus and the testes usually demonstrate activities.
Can you go back
So
one slide for a quick second?
Yes. Here you go. I don't think there's anything for you to write. I think everything was there.
No,
Yes.
there's some words missing. Like it stops at usually at the diffuse, segmental, and nodular focal.
Oh, sorry about that.
Okay. Well, I'm good, and if everybody else is.
Okay.
Yeah, I'm good.
All right. So here's an example of your GU tract, your kidneys filling out into your bladder. Okay. And how important it is for you guys to make sure that the bladder is empty. But obviously this person had a Foley that was put in because as soon as it started to fill out, it started to go out. Okay? All right, now we're going to go into bone marrow, lymph nodes, and the spleen. The bone marrow activity usually is similar to the liver activity. If the patient is anemic, they may have increased activity. If the patient has undergone radiation therapy, there'll be decreased activity. Lymph nodes normally have very little activity, but if infiltration occurs from injection, there may be activity in the axillary or supraclavicular nodes on the site of the injection. Spleen activity is usually low, but can be increased in anemic patients. There's a lot of little details that you guys need to know, okay? So make sure you guys read up, okay?
Yes, ma'am.
All right, here we go. Where is bone marrow normally in the body?
Long bones.
In the bone.
Exactly. Exactly. So you have your sternum, the head of the femur, or excuse me, the head of the humerus, the femur. I don't know too much about the pelvic bone. The vertebrae, yes. I don't know about that pelvic area, but yes, the femur here. Okay. This is bone marrow recovery following chemotherapy. So what's going to happen is you can see the patient is in recovery from chemo, so there's going to be increased uptake in that spine, okay, in the vertebrae and in that pelvic region. So it's very important for you guys to have good patient history, all right? Because this is going to be like the doctor's going to look at this and say, what the hell is this? And obviously it's not a lesion, it's not metastasis because the way that it looks. So they'll know that this is someone who just went through chemotherapy. Okay. Now this is primary tumors and METs. The amount of uptake in primary brain tumors is inversely related to the patient's survival. If the tumor has a high amount of FDG uptake, survival is poor, whereas a hypometabolic neoplasm will most likely be a low-grade tumor. PET scanning is recommended for patients who have received therapy in order to differentiate recurrent tumors from radiation necrosis. Detection of brain mets is usually poor due to the high amount of background due to the normal activity that is usually present in the gray matter. So it's really hard for you or hard for them to distinguish because of the background that's there, the normal brain activity from the gray matter. Okay, this is your brain mets. Well, this is mets in general. All right, now we're going to go into tumor imaging. So the patient prep is that the patient has to be NPO for 4 hours. Your contraindication is high glucose levels will reduce the tumor uptake, which we said before in the PET imaging for the brain. Your radiopharmaceutical would be 10 to 20 millicuries of FDG. The injection to timing or the injection to imaging time is 30 to 60 minutes, and the patient has to void before you image them. The method of administration would be IV. For brain tumoring, the patient needs to be quiet in a dark room for a few minutes before injection and 30 minutes after. And the imaging time would be 30 to 60 minutes. The patient positioning would be for neoplasm of the head and the neck. You would put them supine with their arms down. For lesions of the chest, you would put them supine with their arms up. For lesions of the neck, it may be necessary to do 2 scans, one up with the arms up and the arms down. Okay? For the routine view, you'll do a whole body, usually just below the brain to the knee. So it's the skull base to the mid-thigh. Yes?
Yeah.
Everyone understands that so far? For the
Yeah.
most part, this is exactly what you guys have been doing when you guys have gone to clinic, correct?
Right.
Yeah.
When you guys were doing the PET.
Yes.
Okay, good. All right, this is lymphomas. So this is your FDG versus doing a gallium-67 for lymphoma. Because you can do this for non-Hodgkin's lymphoma, remember? And then this is what the FDG will look like. So obviously the PET is more superior in detecting that. Okay. Now we have misregistration. Yes. The PET is showing, it's not METs, it's showing where the lymph, I guess because lymphoma is not at one steady area, so it's going to go in every area that has lymphs. So if the lymph is migrated to other areas of the body, it's going to go there. So I don't want to say that it's, because they don't consider a person having metastasis until it gets into the bone for the most part. Like in this, right, right.
Those
Okay.
are the lips showing up. The dot.
What'd you say? It's a lot. It's a lot. Because lymph circulates. And that's what, and that's the most important thing that you guys have to also remember, that it circulates. So if it's circulating and it's in that area and it's doing what it's doing, that's where it's going to be at. So what's this area? You guys, please, it's anatomy. Please tell me you know what this is. Lymph. Think of lymphs.
That's
Immune
the
system.
spleen.
Who said it?
The spleen.
Yes. Hallelujah. Does that make sense? I understand, but your liver's on this side.
Yeah.
It is. Oh.
Well, you can kind of see the liver.
This is the liver. This is definitely the look. This is the base of the liver. This is the dome of the liver right here. Okay.
Well, you can tell.
And then the kidney, and then this kidney sits a little bit lower only because the spleen is so large. So this person has right, and the heart's here. Okay.
Can you guys see my drawing or no?
Yeah.
Okay.
All right. So just remember all that when you're thinking about, when you're doing your patients and you're looking at stuff and you're like, what in the world? Just remember anatomy and physiology. It goes back to the basics. Okay.
So this person would have like a huge lump on the side of their head or neck, right?
Yeah, they probably do. Yeah.
This is.
Yeah. All right, so now we're going to go into misregistration. If the patient moves between or during emission and transmission scan, okay, that's what you're going to have is misregistration, results in an invalid attenuation correction and shows as a hot or cold abnormality. There you go. Okay.
We have to write this whole
You
sentence.
have to write this whole thing.
You do? Oh, I'm looking at mine. Hold on. Oh, I see.
Okay.
Okay, hold on. I'm just trying to. Oh, sugar, honey, and iced tea. Okay. All right. This is whole body PET. So, inflammation. Inflammation in any area of the body will be demonstrated by increased FDG uptake. This may make it difficult when diagnosing infection versus malignancy. Fractures. Acute simple fractures are demonstrated by an initially high uptake, but should significantly lessen within 8 weeks. Vertebrae. Chronic benign vertebral fractures have an SUV of about 2, whereas pathologic fractures due to a neoplasm, for example, usually have a higher SUV value, such as 4. Osteomyelitis. The FDG imaging is more accurate than a 3-phase bone scan. But if differentiating osteomyelitis from cellulitis, then the 3-phase bone scan is better due to the hypermetabolism occurring in both cases with the FDG. You guys have any questions?
Pretty self-explanatory.
Yes, and I hope you guys put all this to memory. All right, so now we have a normal whole body. Normally, seen activity would be the brain, the liver, the urinary tract, the heart, and the bowel. Infected catheter. So it's CT versus the PET CT. So you would not have seen anything here, but now you have your PET CT, I should say, and then you see the infection here. Okay? Osteomyelitis, general X-ray, nuclear scan, and then here you have your PET CT. Okay? Gives you a nice, beautiful picture and letting you see what's what. All right, so now we're going to go into the pancreas. Pancreas, increased activity in the patient with pancreatitis. But if the patient may have pancreatic cancer, this would be difficult to differentiate. You guys have any questions?
No.
All right, I'm going to stop the recording. All right, you sure you guys don't have any questions?
There's not anything.
All right, once again, it's 40 slides, right?
Mhm.
There's a whole lot of information in these 40 slides. Okay?
Mhm.
You guys have to make sure you read for this the next test. You really, really do. I don't know what you guys did for this last test. You had plenty of time to actually study for this exam, and I'm sure you guys forgot about it and you weren't ready and so forth, but you need to really do well on this exam. All right?
Yep.
Yeah. PET is very easy. PET is very, very, very easy. As long as you know what you're supposed to see, what you're not supposed to see, what the patient prep is, and then everything for the most part is easy.
Yeah.
as far as imaging goes. Now, instrumentation, yesterday's class is a totally different ballgame because, it's understanding the inside component of the actual, machine itself. But if you have gamma down, the PET should not be hard because it's the same concept. The only difference is that it's the change in the crystal so that it produces more scintillation. That's the only difference. But it's the same concept moving forward. So if you got the instrumentation for your gamma camera down, the instrumentation for PET should be fairly easy.